Okay, good evening, ladies and gentlemen, and welcome to probably one of our largest meetings for this year. So thank you for filling up the theatre and, of course, being part of the Wolper Wellbeing evening. So tonight we're going to be talking about arthritis and osteoporosis, and certainly it's probably one of the major diseases in our society in that it affects over 3 million people. Arthritis can be in many different forms. Looking around the room, age is a cause for it. People often get it when they're younger. Rheumatoid arthritis is a bit more of the severe compared to the more common osteoarthritis. So there may be 500,000 people with some form of rheumatoid arthritis. So for all of us, it's a very difficult disease to manage. As a GP, it's probably one of the major reasons why people come and visit the GP. And on our pharmaceutical benefit scheme, it's one of the top 10 prescribing medications for that ailment. So we have a lot to talk about. And of course, there's osteoporosis, which affects more women than men, is a cause for fractures in something like a lifetime risk in about 42% of the population, adult population. So we're talking about significant disease. So with that, we have some very good people to talk to us tonight. And we'll start off with Andrew Cairns, who's going to talk to us about Arthritis New South Wales. So Andrew, please come and say hello to Andrew, and then we'll meet our other guest speakers.
Okay. Thank you very much, guys. Look, I am standing in for our CEO, Sandra Vincent, and I also send my regards from Nigel Corn, our president of our board. You can see there, I think it's a nice segue for Dr. Schell's lovely introduction to say these are the faces of arthritis, and they are many and varied, and I think some of the more surprising ones that people don't automatically anticipate are the younger faces, and the particularly younger faces that could be upwards of 3 months old. So we do a lot of work in this space, and I think Dr. Schell's really canvassed a sense of how big and unifying this condition is in the nation and the population. But who we are an organisation, a non-for-profit, entirely dependent on donations from the public and the consumers of this condition. 50 years old, and our mission is freedom from arthritis. And I think we've taken a fairly broad interpretation there and a fairly ambitious objective and purpose. And the way we envision freedom from arthritis is the idea that it could be around cure, and this is something that we're all hoping will be just on the horizon, but it's also about instilling people and empowering people to understand the very many self-management strategies they can employ today that might be around lifestyle change, might be around medication management, it could be surgical outcomes that are required. We want to make sure that people understand that these strategies allow people to have quality lives. They can live with this condition, but live a very sort of fruitful, happy and purposeful life. So that's basically what we want to do, and we go about that in 4 ways. Our organisation, first and foremost, exists to spread more information and awareness about all sorts of musculoskeletal conditions, of which arthritis is the major one we deal in. And of course, I think lots of our health professionals here will talk about just how many forms of arthritis there really are when you come down to it, and it's probably not doing the condition true justice to just talk about it as arthritis. There's lots of different forms of it. And we want people to know about that. We want them also to know how they can best manage it. We do a lot of work also in the advocacy space, talking to policymakers and people that may have the power to influence change on sort of system levels around the government and health systems, so that they can truly appreciate the real cost of this condition, not just from an emotional perspective, which is really impactful and important, but I suppose their ears prick up a bit better when we start to talk to them about the financial costs, the burden of this condition in terms of the finance, both on a personal level, but also on a national level. Those arguments would probably not be as compelling as they can be if we weren't also very active in the research sort of space. And we're mostly linking ourselves with really, very prolific research institutes and academies and various universities, and helping to contribute to what they do, perhaps in the form of giving funds and financing some of their work, or connecting them with consumers that may go on to be involved in the studies that further our understanding of all of these conditions. And fourth, and by no means least important, we are really passionate about creating support and environments where people can feel supported. And that may take the form of things like support groups, because I've been educating in arthritis and osteoporosis for a many number of years now. And I know that I might come with a background in exercise physiology and some hopefully fairly relevant and reliable information, but often that can pale in comparison to the information that a peer that may have lived with that condition can give you as well. There's some insight and lived experience that has true authenticity that hopefully is as effective and evidence-based, but there's a lot of value from hearing that from someone who's walked in your shoes and understands that. Does that make sense? That's what we're here to do. So how do we go about that? Well, we have various ways that we try to achieve these goals, some of which I know many of you, I'm very encouraged to see so many of you have taken some of our resources tonight, and I hope there's some left when we finish the session tonight, but it's great to see how ravenously you've picked up that information, and that's one way we talk about educating people on the conditions, but we also have a couple of active services as well. We've developed things like warm water classes, strength and balance classes, community education sessions, so again, something like this where we'll go out to the community and deliver education to groups of people so that they can better understand the conditions. And we do some really important and a personal sort of passion project of mine is the work we do for children with juvenile idiopathic arthritis. Again, we run 2 camps for this population, and those children can be as young as 3 months old, but it's really important that we sort of spread some love and attention and education and awareness to them as well. And we've also got our info line. So if you're ever sort of needing some on-the-spot information, you want to understand a bit more about the symptoms or ways that you can manage it, take that number down and please feel free to give us a call, because we've got a lot of health professionals online that can give you some advice, maybe some further referral pathways to get the kind of information support you need. So I promised I'd keep this very, very short, and I think I've kept that promise. So if you do have any other questions, please come and have a chat to me after the presentation, and I will be part of the panel. But thank you very much for allowing our organisation to be involved in what will be a no doubt very successful night. I thank you once again. Thanks.
So thank you very much for that, Andrew. And of course, we need to introduce what Wolper does. Wolper's been involved in rehab now for well over 15 years. And I and other people in the audience have had their hips and their knees rehabilitated post-op because of osteoarthritis. So I'm going to introduce Cody Kay, one of our lead physiotherapists, just to have a brief talk about what Wolper does in the realms of rehab and post-op. Thank you.
Good evening to everybody. Lots of familiar faces here, which is nice to see. I guess on Wolper, one thing I wanted to go over is not only the services that we offer, but also the thinking and the rationale about what we do. So lots of people associate us with sort of the end-stage arthritis and joint replacement and rehabilitation then, but I think there's a lot of work that can be done sooner, and I guess this has kind of been an idea behind some of the services that we have started to provide. So other people would know us about the Move Well program and the 49 classes we offer there with aqua classes and strength and balance classes. We've also sort of gone into the realm of the private physio and private EP and then the private hydrotherapy as well, because with these, I guess, within the rehabilitation, we have lots of experienced staff that see the end stage who can actually be great advocates for what you can do beforehand. So there's sort of additional things that we've started to get into, which has been quite good uptake so far, but I think as we start to get further into that area, people will start to be able to see Wolper as sort of a one-stop shop where they can look after you prior to, and then if you do have to go down the line of joint replacement, well then we can look after you at that stage as well. And I think the other thing with the Move Well program is not only after you have the joint replacement, it's also a good time to keep moving and doing things because you don't want to then go down the line of another joint replacement or you want to delay it for as long as possible. So I think on the services we provide, like I said, there is some private services, so private physio, private EP, as well as our Move Well classes, which are all on the website, and you can always call the hospital or drop in. And I think one of the best things is when people drop in or they participate in the classes, they get to actually see the environment and see what we do and see how positive it is in there, because this condition can be quite crippling for a lot of people, so it's nice to come in and be familiar with the surroundings and enjoy what you do. So I know there is some familiar faces here. Hopefully more of you will become familiar to us, but I'll hand back over to Alan and then we can introduce the other guys.
Okay, so enough of the advertising, but I think you understand what's out there. Please, mobile phones, if we can put them on silent or turn them off so we can have a bit of politeness for the speakers. So our first speaker is Professor Rick Day, followed by Professor John Eisman and Matthew Williams, and then we'll have, as we usually do, time for you to ask questions when we invite the panel, including Andrew, to answer some of the questions you will pose, and I'm sure they'll be answering that for many other people who didn't ask a question. So our first guest speaker is Professor Richard Day, is a Professor of Clinical Pharmacology and a Rheumatologist, as we see up there. He also has been honoured with an AM, and part of his work has been involved in rheumatology and musculoskeletal medicine at St Vincent's Clinic. So I'd like to invite Professor Day to come up and talk to us about Live Better with Arthritis. Thank you. Over to you.
Thank you. Well, good evening, everyone, and thank you for the opportunity, which I really appreciate. And I've had a lot of pleasure referring people to Wolper for rehab, so it's a place that does an excellent job. So I'd like to take you through a bit of a tour of arthritis, the various sorts of arthritis, and how we tell the difference, and what we can do about arthritis these days. So the first point to make is that this is a big problem, as has been mentioned already. So it is the commonest cause of disability and pain. It costs a huge amount of money, directly and indirectly, and you can see how many people are affected. 1 in 6, which is a huge number, 17% of us, and of course more as we get older. And for early retirement, it's the second commonest cause. So it's a huge matter, has a big effect, probably been underrated. Now what I want to do now is tell you about, there are just 2 broad categories of arthritis. We'll call them the major types. Now the commonest one, which probably afflicts a lot of people here, is the non-inflammatory group, and the key diagnosis here is osteoarthritis. Sometimes that's called osteoarthrosis because inflammation and itis are almost synonyms. Back and neck pain we put into that category, so everyone unfortunately has back and neck pain or gets it. And then there's all the muscle aches and tendon problems. So people have had tennis elbow, if we put our hands up, those who can, if they've got tennis elbow, golfer's elbow, and these are incredibly common, so musculoskeletal problems are really big ticket item. The other huge category is the inflammatory category, and that the index here is rheumatoid arthritis, which many of you have, but down below that are a group of disorders that are rather similar but are associated with other common inflammatory conditions. So people have this skin condition called psoriasis, so there's psoriatic arthritis. Inflammatory bowel disease, that's Crohn's disease and ulcerative colitis, and a proportion of people have inflammatory arthritis. And a whole bunch of arthritises that are reactions to infections that can go on. And then there's the category of what we call the connective tissue disorders, and this includes things like lupus, Sjogren's syndrome, scleroderma. And my favourite disorder there, gout, and anyone with gout, I'm going to recruit you later in the evening to come and help us on some research. And then something quite unusual called pseudo-gout. So it's like gout, but it isn't. But it causes a lot of problems. So they're the 2 big categories that afflict people with arthritis. So the question is, which one is which when people have these problems? Now, in order to address this problem, we just need to revise a little bit about what a joint is. So these are the bones. This is the articular cartilage, and that's really important because as that is attacked and damaged, it leads to pain and disability and loss of function. Around all of this is a capsule, very important to hold things together. But I just want to emphasise this thing called the synovium. It's like the membrane inside your mouth. It's just a very thin membrane with cells, and it sort of is like a balloon that wraps around a lot of the things inside the joint. So see if you can remember this diagram, because it's important as we try to figure out the difference between these types of arthritis. Articular cartilage, synovium. And by the way, the cartilage, the meniscus, people have heard of meniscuses, maybe from soccer players, netball players, basketball players, often tear something called the meniscus. It's not up here. It's a different type of cartilage. It's a bit like the cartilage in your nose, sort of a flexible cartilage, but that can cause trouble too. So remembering that, let's get back to differentiating between these big categories. So we'll start with the commonest one. That is the osteoarthritis group, non-inflammatory group. Well, what are the symptoms? Well, obviously pain, but the one important point is that something called inactivity stiffness. And you'd all know this. If you have a bad knee or a bad back from this condition, and you sit down and you're not doing anything, when you get up, it's stiff. You go, oh, I can't move it. And after a bit of movement, you can. That's called inactivity stiffness. Whenever you stop, you get it when you restart. The signs, the joint gets bigger, and it's not soft swelling, it's bony swelling. It's a reaction of the joint. And I'll show you the distribution, which is very characteristic, but if you remember that the hips and the knees are very much targets for this problem. Now this stands for laboratory, by the way, not those dogs called Labradors. I just noticed that. There are a couple of blood tests here which we don't have to do, but they're often done to measure if there is inflammation in the blood, in the body, and there isn't in this condition. No inflammation of a major sort. So that's the non-inflammatory OA. Now, these hands here are typical of what we call nodal osteoarthritis, and you can see there are knobs on the end of the fingers, and there is involvement of this line of joints. That's what we meant by distribution. It's symmetrical, it's absolutely typical. This is inherited pretty strongly, mainly much more commonly in women. So if your mother had it or grandmother, that's most likely that the reason you've got it yourself. That's a bit different from the hip and the knee inheritance. But what you can see is the knuckles are spared. The other common place is the base of the thumb, right there. And that's very typical of osteoarthritis. It's not rheumatoid. You don't have to worry that this is going to be very destructive. Now, who thinks this person's got bow legs and who thinks this person's got knock knees? All those in favour of bow legs? Okay, you're right, so we don't have to ask the second one. So this is the inside of the knee. Now that's what a normal knee looks like. If you take an X-ray standing up, so the big bones pushed against each other, that's the articular cartilage that we showed before, and that's good. That's what we need to see. This is not so good. On the inside of this person's knee, we've lost it. And that's typical of osteoarthritis. There's bone being produced here, the joint's getting bigger and it hurts. And it's stiff when you're trying to get up, and it hurts a lot. It can do. So, very quickly, what are the goals of treatment? They're pretty obvious, but there's just a couple of bits I wanted to emphasise. Obviously, that's obvious. We've got to help with pain and stiffness. That's not so obvious. The whole thing went off. The very important thing is that we want to keep people functioning as long as possible, and that's what you want. So a lot of the physical therapies that we've been talking about and approaches are designed to do that, and they're very effective. But very importantly, and I just wanted to reassure people that we have very good evidence now that if we get onto this early with a good program, we can slow the progression and stop it almost in lots of people so they don't need surgery at the end of the day, which is a good thing. So what are the therapeutic options? Now, I put that up there. If we stopped injuring ourselves when we were young, that's a different topic, that would help. But once we get older, if we get unfit, we get overweight, we're not active, and we have flat feet and various other things we could do something about, we're at risk. But if we take note of those things, we could prevent a huge amount of osteoarthritis of the knees and the hips. Something to talk about, to focus on. This little box here, all of this is what we call evidence-based, that there's very good research evidence that what's up there works exceptionally well. That is, knowing about it, Arthritis Foundation, Arthritis New South Wales, a proper program. Not only does it slow progression, we could actually show on MRIs that some of that cartilage regrows, repairs. And that's an amazing finding. We were very surprised when we saw that, but that's the case. Now, all those who have heard of paracetamol, what a ridiculous question. So it's in the drinking water. Now look, if it helps, that's good. If it doesn't matter, but it's safe, generally safe, as long as you don't overdo it. Then there are a whole bunch of drugs called non-steroidal anti-inflammatory drugs which were mentioned, such as Nurofen, Voltaren, you've heard of, and even these COX-2 selective drugs. People have heard of Celebrex, maybe, Mobic. They're a little bit more effective probably, but they have side effects, and particularly as we get older, some of those things are a bit risky, such as ulcers, a kidney problem, a heart problem. What about opioids? All those in favour of, no, ridiculous question. None of us are in favour of opioids, but sometimes, but I think it's a very important decision. If we're going to prescribe codeine, oxycodone, endone, that's a big call and we need to be incredibly careful. So we'd rather avoid that. Lots of people have injections, they can help. They don't stop the process, but can be helpful for acute problems, say, of a knee. And look, I love surgeons, but they're at the bottom of the list, and we try to avoid it if we can. Now, can you take a breath? Because we're going to do the inflammatory bit very quickly. And Mr. Chairman, if you just go like that, I should get off the podium, I'd be grateful. Now, because we're in medicine, we like to speak in a language no one understands, so this is Latin. There it is there. So these are the signs of inflammation. Redness, swelling, heat, and pain. That's the signs of inflammation, and that's what we see in the inflammatory arthritises and loss of function. So, now look, I'm a bit of a bit over interested in this condition, but it's the most inflammatory condition there is. So I thought I'd just show you very briefly an example of a very inflammatory condition. So interestingly enough, the commonest inflammatory arthritis in men is this. And as you can see, that's very painful. People say, I can't bear having a sheet on that, and that's repeated so often you think it was the people were in the know and had told each other. Now, amazingly, we still see this. So this condition is very prevalent. It's getting more prevalent. But the amazing thing is we can actually, this is one arthritis that we can actually, use the word cure. We can prevent it, but we don't, or we haven't. Now, gout is no laughing matter. I thought I'd show you this. This is a letter to Henry Walpole from Mary Wortley Montague, and what she said is, people wish their enemies dead, but I do not. I say give them the gout. Now, this lady is a very interesting lady. Here she is. She's pretty tough, and here's Alexander, that's her. Lady Montague laughs when Alexander Pope declares his love for her. You see the sort of woman she is? She's a very tough hombre. But the point is, it's an incredibly nasty condition. Here's what it's caused by. Uric acid, which is everyone's got in their blood, but in the case of people with gout, it forms crystals, which cause inflammation, particularly in the joints, and it's an incredible inflammation. And this is my plug, which for the famous gout study where we're testing an app. If you're interested, know anyone with gout, and especially women whose partners are not here, that would be really good because that's important. So how do we differentiate this inflammatory group? And it's a bit like the setup we said for the non-inflammatory group. Now, there's stiffness here that's different, and it's called morning stiffness. Now, the men in the room will know what I'm talking about. No, that's a joke. The stiffness is when people wake up in the morning and it's intense and its duration is indicative of how inflammatory this condition is. So very different to inactivity stiffness. The other thing is tiredness. Everyone gets tired, but this is intense tiredness. So a person who is reasonably energetic suddenly says, hang on, I can hardly do anything. And those two things should get better when we treat this condition properly. The signs here, the swelling's not hard like in OA, it's soft. And the distribution is different. And here's those inflammatory markers, they're increased. So that was the contrast with the non-inflammatory. So as a doctor, a general practitioner, when you tell them the story and they have a look, the differentiation is pretty much a clinical differentiation. And here it is, and you'll notice the difference. The knuckles are affected, the wrists are affected, these muscles are wasted. You probably can't see it, but it's in those joints as well, not at the ends of the fingers. So it's very different distribution. Symmetrical again, and it can affect symmetrically any joints. Now, what's the difference? Remember back to that diagram. Remember the synovium? Well, here it is now. And this is called synovitis. This is called an autoimmune disease. Our immune system decides that this is no longer part of us and it's going to attack. And that's what it does. And this huge mess of cells with destructive enzymes and so on that damage that articular cartilage. Lots of fluid, the joint swells, the capsule swells, the joint becomes unstable, and the rest is history. Now here is not a very nice picture, but what you see is it also affects tendons, because tendons are in sheaths of this synovial tissue. So it's attacked as well, they can even rupture. Symmetrically affecting the feet, the hands, and this is a very bad example, and our job is to stop this, and we can. And that's one of the big points. Remember that single little membrane? Well, that's what it looks like when it's out of control rheumatoid. All of those things are buckets of cells that should not be there. So what about the prognosis here? Because this is very important, one of the most important things I can say. So if we don't get onto this, we'll definitely have disability that can't be reversed easily in 10 years. And by the way, mortality increases if we don't do this. One thing we've learnt is if you have inflammation and it's uncontrolled, it's a risk factor for cardiovascular disease, as it says there. And I'll put this in blue because that's a very important message for anyone you know who thinks they have rheumatoid, that if we get onto it, we can improve the outcome hugely, and even to the extent of stopping it these days. So here's a picture of people who, and we're measuring on this axis a measure of the progression of damage. It's an X-ray measure. And here are people who turned up, diagnosis made, treatment started over 3 years. And these people started 3 months later, not long, 3 months later. And already they've moved up there and their end result is not good. So that's the point of getting onto it early. Now, again, in what we can do, we must get onto this because really we need multidisciplinary help. All the people in the front row who have talked and are talking, we need to understand it, we need to have a physical program, psychological support, etc. NSAIDs, they can help, they don't stop anything. Prednisone, cortisone, everyone's scared of that. We use it a little bit initially, not great at stopping things, but it helps people get started. A few old drugs, interestingly enough, discovered by chance, and some people here are on these drugs taken by mouth. This is our key drug, and it's a bit frightening when people come in, they haven't got much to see, they've just got the stiffness I talked about, and we say, we think you need methotrexate. Then you look up the product information and you look at the list of side effects and you think, hang on, I'm not taking that. But actually it's incredibly safe. We use very low doses. We track it carefully. I think it's safer than Nurofen, personally, if we do it that way. And this is a drug a bit like that. And lastly, this is the big advance in this field. Some of you are on some of these drugs called biologicals. They're on the PBS. If we haven't succeeded up to this point, they cost about $15,000 each per annum, so we have to be careful. They're very specific and they've revolutionised the management of this condition. There's quite a lot of them now. And in order to get to the point of suppressing all the things I showed you, the swelling, the stiffness, the tiredness, the best thing to do is to use combinations, if needed, to get to that point as quick as possible. And I just wanted to show you one picture. That thing there is a molecule. It's called tumor necrosis factor. We know it drives inflammation. It's not the cause. And normally, what it does is hops down and it hooks up onto these two receptors on a cell, and that drives the process. But we've been able to engineer, molecularly engineer, more or less the same thing with a bit of a bridge, which knocks it out. That's how one of these biologicals work. Incredible advance, and it made a huge difference. So I'm going to conclude. I apologise for the speed of this Cook's tour. This is what I'd say to anyone when they're thinking about arthritis. Get to your GP early. I hope I've emphasised early helps. The other big message is we can prevent a lot of this, a huge amount, particularly the osteoarthritis. By the way, if you happen to be smoking, give up now because it's a risk factor for rheumatoid, and there are various other things we can do to help prevent that. We can control most arthritis well, and I should have put New South Wales here, apologies, but anyway, Arthritis Australia, there's a wonderful site, lots of information. Thank you.
Thanks very much, Professor Day. Our next speaker is Professor John Eisman. John has certainly been one of the lead researchers and serious players in the world of osteoporosis in Australia, and certainly has for many years been at the forefront of research and in setting up research teams and a number of societies to sort of look at. You looked at arthritis affecting 3 to 4 million people. Osteoporosis is over 1 million already. And while we're talking about joints, we're now going to talk about the bones that in fact support the joints, and when they get porotic they break and you're in big trouble. So we're going to now hand over to Professor John Eisman to talk about osteoporosis. Thank you.
There's got to be a way of this thing. Okay. Thank you all very much for being here. This is great. This really is a full house. That's delightful. What I'm going to try and do in the next little while is to tell you why you should be interested in osteoporosis, what it actually is, understanding something about risk, because that's a very important part of managing our life and well-being, understanding some of the potential benefits of effective therapies. And there's a pointer here, so I should be fine. I hope. Rick is obviously offering me his pointer. Now, one other comment I'll make, there are question time at the end. If your memory is like mine, it's a good idea to write down some questions as we're going through, the questions that relate to what Rick said and questions to what I say, because otherwise you'll come to the end and you'll think, I know there was something I was going to ask, but I've forgotten what it was. So make some notes if you can. Okay, so osteoporosis, from what we really care about is that people get fractures when they wouldn't normally. Now, there are a lot of ways of defining this. Medicine uses some definitions that actually aren't terribly helpful. But I always ask somebody a question if they've had a fracture. I say to them, if exactly this event happened to you when you were perfectly healthy in your 20s or 30s, would you have expected to have broken that bone? And unless somebody can say yes, there probably is a fragility fracture, it's probably an osteoporotic fracture. There's no point in asking, are you surprised that it happened when somebody's in their 70s or so forth, to say, yes, of course I expect to break it because I'm getting older. But that actually is osteoporosis. And that's the thing we've got to try and focus on because we can probably do better in that regard. And the importance of knowing about a fracture having occurred is not that our orthopaedic colleagues can't fix them, because most of them, not all of them, but most of them they can very effectively. But the problem is every osteoporotic fragility fracture, every single one of them, with some very minor exceptions, signals increased risk of further fractures with the associated pain and disability and loss of confidence and loss of quality of life, but they also signal increased risk of death. Now, that's actually probably the wrong way of saying it, because we all die. It's actually of premature death, and that's not much fun. And the important thing is that we have treatments now that are available. They are well tolerated, remarkably well tolerated and safe, and they can reduce the risk of further fractures and probably also improve survival. This is actually a very good news story in this regard. So, this is some of the work that we did when we were in Dubbo. This is a skeleton, which I'm sure you can recognise. And this shows just some of the fractures that occurred in men and in women that we followed over about 10 or 15 years in this particular analysis. And what's interesting, I think, well, I'll ask you first, can you see which bones have not fractured in these people in Dubbo? Can you see any bones that haven't in the skeleton there? The skull. The only place where we don't see fragility fractures are in the skull and the head and neck. And it's interesting, I mean, I'm not going to talk about bone density measurements that goes down in all of us as we get older. The only place where that doesn't happen is the skull, where it actually goes up as we get older. And you can make what you like of that. But basically, every one of these bones fracture. And please note, there are about twice as many fractures in women. There are more older women, so but relatively speaking, there are about twice as many fractures in women as in men. Now, we often think about osteoporosis as something that just happens in women. This is absolutely untrue. It is something that does occur more commonly in women, but actually, as I'll show you, it's actually a worse problem in men because men do worse with it. And it's not just because men are wimpy. They actually do worse with it in real terms. So every one of these fractures, with one exception, which nobody understands, is that ankle fractures in women do not signal increased risk of other fractures. Now, whether this relates to high heels or something like this and the excess forces that are placed on the female ankle, we don't know. But that's the only one that isn't. Every other one, and there's basically nothing here. There's no part of the skeleton where you don't see these fragility fractures occurring. And the other thing is, we sort of know that osteoporosis becomes more common as people get older. But the fact is, and I'll explain this diagram in a moment, is that as people get older, they tend to die. So there are fewer people. So in this particular study, this was looking at probably close to 100,000 women around Australia who were asked had they had a fracture after their age of 50. And this just describes, these are the different age groups here along the bottom here. It doesn't matter the precise age groups. I'll come back to that in a moment. And these are the numbers of women who said they'd had a fracture. And what you can see is this diagram goes up and goes down. And the peak incidence of people having said they've had it, women saying they've had a fracture after the age of 50, the peak incidence is before age 75. And that's probably for two reasons. Firstly, there are fewer women alive after the age of 75. I mean, I'm not referring to the audience here, but it is what happens, and it's more marked for men. But the other thing too is all of these fractures that have occurred increase the risk of people dying prematurely. So the people who've had the fractures are less likely to make it to older age groups anyway to say they've had an earlier fracture. Leastwise, that's how we interpret these data. So this is not a problem of the old. Yes, for the old, it is more of a risk. But for the young old, like myself, it is, in the community scale, it's a much bigger risk. It's a much bigger risk in the young old. And just to put that in perspective, this is showing the incidence of fractures that we observed in our Dubbo population. And this is a group of people who kindly agreed to participate, and we followed all the events that occurred. This is in women and men, 60 to 70, 70 to 80, 80 plus, and these little boxes represent the numbers of events. And without going into the numbers, you can see for the women, colour-coded in red, about twice as high as they are for men at each of the age groups, not quite so much in the older age groups. This is for one fracture, a first fracture. If these women or men have had one fracture, you can see this is the risk of another fracture in the same age groups. And you can see for women, it pretty much doubles. For men, it goes up fourfold. So the protection of being male disappears as soon as the male has had one fracture. So a woman who's had a fracture and a man who's had a fracture have the same absolute risk of another fracture. So the protection of being male, suddenly disappears. And this is in spite of the fact that men are more likely to die. They're more likely to die anyway, but they're even more likely to die after one of these sorts of fractures. And I won't go into this in detail, but this is the looking at the risk of death. This is in women who have had a hip fracture. I'm sorry, I should have changed that. That's our medical terminology for a hip fracture, a spine fracture, or any of the other major fractures. You can see the risk of mortality compared to other women of the same age and with other same medical conditions, the risk about doubles, and for men it goes up 2 to 3-fold. So men are even more likely than other men. Men are already more likely than women of any age to die, but they're even more likely relatively more likely to die prematurely if they've had one of these fractures. I point this out, osteoporosis is not a benign condition, okay? Now, when I first started working in this area, if I was going to put up this diagram, which is age and what some of the things you might know or do, the only thing I would have put on it is this little red dotted line, which said is that as you got older, the risk of dying went up. We had no evidence for how to measure bone density, which is this one here, which goes down in all of us as we get older. We had no validated treatments. By that I mean properly done randomised controlled trials showing that a treatment actually makes a difference and reduces risks and improves outcomes. We now have so many different possibilities here, of which I'll try and very briefly touch on in the next few minutes. Now, one of the other things is that people say, what is the most important thing you can do to reduce your risk of the condition, in this case osteoporosis? Now, Rick said, well, for arthritis, it's exercise. For osteoporosis, it's choose your parents carefully. I won't go into what this slide actually shows, but it compares identical and non-identical twins, looking at the bone density. And if you just say, look at this one up here in the top left, you can see if you plot one twin against their co-twin, their numbers are almost exactly the same. They fall on this straight line at 45 degrees. If you look at the twins that are non-identical, they're scattered, they're similar, but scattered around the line. This translates to being somewhere between, depending on where you measure it, somewhere between 40% and 90% heritable. I mean, you can only get 100%. So it says this is very highly inherited. And this is some work we did when patients came to me and said, I'm really worried about osteoporosis, it runs in my family. And this is not done that long ago, maybe 20 years ago or so. Until that time, nobody had really thought about it. So there's a lot of discussion about, you know, the role of other lifestyle and so forth. And although I always encourage people to, you know, follow a healthy lifestyle, the evidence is choosing your parents wisely is very important. Now, unfortunately, by the time you give people that advice, it's usually a bit late. So, what are some of the things that you can do? And lifestyle probably does have some role. Making sure you have adequate vitamin D is important. It has a small effect, along with making sure that you have an adequate calcium intake. By themselves, these are no panacea. They don't cure everything. But we are in a situation where people really try to avoid the sunlight as much as possible to avoid the skin cancer problem and the melanomas, etc. And actually, as people get a bit older, we tend to go out often more completely covered, you know, hats, sunscreen, etc., avoiding the sun. And very often we see that older people, by that I mean my age, that we have low vitamin D levels. And that's probably not a good thing. And also, as people start to focus on their diet to make sure they have healthy diets, they tend to avoid dairy foods, which are associated with fat, but that's not necessarily the case. And then they have a relatively low dietary calcium, and that's not a good thing to add. Physical activity is probably good, but I do point out that you do need to be a bit careful because many is the time that people injure themselves when they start doing physical activity, you know, particularly if people don't have good advice and care and information as they're trying to do it. It's a good idea not to smoke. I always advise people that they should not drink as much as their doctor does. And reducing falls is interesting. Most fractures tend to occur when somebody's fallen. And it's very clear there are some interventions that can reduce the risk of falls. Not completely, but reduce them. What's not been so clear is that the fractures, the falls that you've prevented are the ones that were going to cause the fractures. So the evidence that you reduce fracture risk by reducing falls is a little bit soft. Now, I still recommend all of these things, but if somebody's got a problem and they've got a fracture, we have really effective treatments that we know absolutely reduce the risk of fracture. So I'll try and explain this. This is a diagram. This is looking with one of the first randomised controlled trials that was done of drugs to treat osteoporosis. This was one that was very popular. This was initially 20 odd years ago, and that was then the first randomised controlled trial showing a drug called Fosamax or alendronate, which commonly people used. It had to be taken in a very difficult way, etc., etc. But what it showed is that it reduced the risk of most sort of spine fractures by about 50%, which is pretty good. Is that? I'm sorry. I hope you can hear me when I'm talking. By about 50%, and other fractures by 30 to 50%. Now, the one other thing it did is it reduced the risk of multiple spine fractures by 90%. Now, they're the fractures that take you from looking like this to looking like... Okay? There should never now... I mean, Rick showed that horrible slide of the gouty tophi arthritis that nobody should ever have now. We should never see somebody now. It is not necessary. We have treatments that can stop it. No one should ever get like that, okay? So we know that that can happen. We know that we can reduce that risk. But the point I would make is this is true of almost everything in medicine. We don't stop everything. We reduce the risk. We delay the risk. We move it later in life to where it has less of an impact, finally, in terms of quality of life and survival. And this is very effective. So this is one particular drug It's called a bisphosphonate. There are others, which is another one called Actinol, which is now in an enteric-coated form, which is much more convenient to use. There's one that's intravenous called a cluster, which one dose lasts for about a year and a half. That's one type of drug. And another type of drug is this one called denosumab. It operates in a different way. What this is showing is these are the people in this study. This is going out for 10 years. These are the people who have been getting good health care but not getting the treated drug here. And this is the risk of the fractures in the people who were given the drug, reduced by about half. And this is for spine fractures, this is for non-spine fractures, and you can see that risk appears to be lower. What's interesting, and this is true of all ethical studies, it's actually not ethical to continue people on placebo for many, many years. So in this study, people were on placebo for 3 years, and then people continued with the active drug. And you can see that the risk of fractures remains low. We would expect that this risk, as you can see here, would actually go up if the people were not treated, because that's what we see. Okay, as people get older, the risk goes up. And here you can see the risk appears to be coming down too. Now, there's some people that say, well, we don't have randomised controlled trials out to 10 years. We never will have them. They would now be totally unethical and could never be done, not in any Western society. Now, the other thing that's fascinating is that one of these studies, using an intravenous drug, zoledronic acid, a cluster, was given to people who had had hip fractures. And this showed there were fewer fractures that occurred in these people. But what it also showed is there were nearly 30% fewer deaths over a year to 2 years in these people who were given the drug. Now, you won't have heard people talk about this very much because people get very concerned. Well, it wasn't, quote, a primary endpoint of the study. We can discuss this later if you want. But it looks like this is true, and we've seen very similar findings in other observational studies that we've done. Now, there are some potential side effects. As one of our previous Prime Ministers said, there's no such thing as a free lunch. That's actually true for exercise too, by the way. There's potential downsides. And there are some things, people talk, that's very sad. Okay, let me go back, all right? One of these is something called osteonecrosis of the jaws, and it actually does occur. It is really quite uncommon. It's perhaps 1 in 10,000 person years of treatment, in terms for osteoporosis anyway, and it's a problem. We now know how to manage it better. It's less likely to occur. If it does occur, it usually can be managed very effectively. There is another thing which we're seeing a little bit more of, is an unusual sort of fracture. Now, we're trying to prevent fractures, but there's a fracture that can occur in the middle of the thigh bone, a very unusual fracture. It's called an atypical femur fracture, femur being the thigh bone. But again, it is very uncommon, and in one of these studies that was done in Kaiser Permanente in Southern California, which manages a population about the same size as the state of New South Wales, in one healthcare fund, it showed that for one atypical femur fracture, there are probably at least 115 typical femur fractures that would have been prevented, maybe 500 or 1,000 other fragility fractures that would have been prevented. So clearly it favours treatment. This was an analysis published by somebody who's done in Canada, and this is a funny way of showing things, so I'll try and explain it relatively slowly. This is something which has an incidence of 1 in 1 million patient years. So 1 million people followed for a year, or let's say 100,000 people followed for 10 years. That would give you 1 event per 1 million patient years. This is 10, this is 100, etc., etc. These are the risks of fractures occurring up here. They're very high risks. And these are the risks of some of these other things that we've just talked about. The difference between here and here in terms of risk is about 1,000-fold. So the benefit that you might get for the treatment, halving this risk, probably means that it's still 500 to 1 in favour of the treatment. Now, I think if you're like me, you're very bad at understanding risk. So this guy put in a couple of interesting things here. What is your risk of having a fatal car accident in the same time interval? And you can see for most of these things, you're probably 10 times more likely to have a fatal car accident than you are to have a side effect of these treatments, and actually being murdered is about the same sort of risk. So I think it's important to say, yes, there may be some risks, but the risks are absolutely low. Now, one of the things, when I've been working at this stage at St Vincent's for about 30 odd years, 35 now, so maybe it's 32, 33, we did this study. And what it showed was that here, most of the people who went through our hospital and were seen by our orthopaedic colleagues about as far away as I am from Professor Day now, that's where our clinics were, less than 10% of them got their bones checked, less than 10% of them got a treatment. And so we said, all right, well, let's try and see whether we can organise that all of these people get a bone density. We couldn't get to all of them, but about 40% of them got a bone density. It made absolutely no difference to treatment. And then we finally set up what is effectively now called a fracture liaison service, where we saw the patients. We got to most of them, not all of them, and about 80-odd% of the ones we thought needed to be treated. And what was really good is that when we followed these people up a year later, a large majority of them were taking treatment. Incidentally, if you're feeling occasionally guilty that a doctor's given you a treatment that a year later you are not taking when he said you should take it forever, rest assured you're about the same as about half the population. I'm not trying to encourage you in that. I'm just saying it's a real challenge. So I'm going to finish now with what I consider are the key points. I haven't stressed it before, but look around. If you're a lady, see the women sitting next to you and be very apologetic to her, well, because she's going to get a fragility fracture or you will. That is basically what the evidence is in Australia, okay? And that really is what the numbers are. And for the men who are vaguely feeling smug at this stage, they should look at the men on either side of them, because one of you will get a fracture. That is the incidence in Australia. It is huge. It is probably one of the most common problems that the general practitioner will be facing, perhaps even more than arthritis. Sorry, we're always competing, aren't we? But it's a very common problem, and it is generally not terribly well managed. The healthcare costs. I think it's hard to think about billions of dollars. I have no idea what that means. But the estimates that we've made is that in Australia now, the direct and indirect healthcare costs for osteoporosis is $1, roughly, it might be a bit more now, but when we estimated $1 a day for every man, woman and child in Australia, every day, every month, every week, every year, and it goes on. And this is not the cost of medications. This is the cost of treating the person and the cost of healthcare costs and the loss of productivity, etc. It is a huge cost. And worldwide, we still have the problem that the majority of people who have had a fracture don't get it treated to reduce the risk of another fracture. They get the fracture treated very effectively. But we now have treatments that are available and should be used, and we're getting a bit better at it. But part of the problem is that people think, well, I've had the fracture and the orthopaedic surgeon's fixed it, so the problem's gone. Well, that's like saying I had a heart attack, they put me in hospital for a while, it's gone now, I don't have a problem. Nobody would say that, okay? And we shouldn't be saying that here. We know that we've got treatments that safely can reduce the risk of fractures, and we believe, based on other evidence as well, that it can actually delay premature mortality, which is actually, and that's with good quality of life. And it depends on a partnership. This is key. The orthopaedic surgeons, the fracture liaison service, GPs, specialists, and the key part that as patients we all play, which is adherence to treatment. A treatment in the bottle, in the medicine cabinet, does absolutely nothing except improve the bottom line of a pharmaceutical company, but it certainly doesn't help us or the country. And with that, we can get fewer fractures and better survival. And I'm going to stop there. I thank you very much. Please, if you've got any questions, do try and jot them down. I'd love to answer them later. Thank you very much.
Thank you very much, Professor Eisman. We now have Matthew Williams. Now, Matthew is part of the Osteoarthritis Chronic Care Program at Royal North Shore, and they, over the last few years, set up a very important program to, I guess, reduce the pain of arthritis, make people more active, and are part of a national strategy action plan for arthritis. So I think with great interest, we'll introduce Matthew in a moment, but just to say that, as John has said, we do have time at the end for you to ask some questions, so please try and write them down and remember them. Matthew, please come and give us a talk.
Thanks, Dr. Schell, and thanks to Wolper and also Ruth as well for inviting me along tonight. It's a pleasure to be involved, and a fantastic turnout as well. I haven't seen a turnout this big since a Star Wars premiere. It's massive. So my real passion over the last 8 or 9 years has been over the other side of the bridge at Royal North Shore Hospital, coordinating what's called the Osteoarthritis Chronic Care Program. It's all about looking at ways outside of surgery and pharmaceuticals, but it's utilising pharmaceuticals as well to manage osteoarthritis. And a big component is educating patients about what osteoarthritis is, but also empowering them with the benefits that exercise can play. And so we'll dive in a little bit more detail around that. As has been mentioned, osteoarthritis is very prevalent. 1 in 5 individuals suffer from it. It's not a condition which is just exclusive to the elderly. A large proportion of the population are of working age. It's a disease that affects the whole joint, so it's not just the cartilage, as has been pointed out. It affects what's called the subchondral bone, just beneath the cartilage. It affects the lubricating mechanism of the joint. It also affects the muscles that surround that joint. Invariably, the muscles which provide a very important supportive function can become inhibited and very weak, which tends to worsen pain, increase the risk of falls, and make people increasingly immobile. A very important point to emphasise is that a lot of people that suffer from osteoarthritis suffer from varying degrees of pain, and that creates fear. And it's important to know that pain doesn't necessarily equal damage. It doesn't mean that you're doing damage. Equally, a lot of people in this room probably have x-rays and MRIs and a variety of other scans which depict all sorts of scary sounding explanations about what is wrong with the joint: meniscus tears, grade 4 severe bone-on-bone osteoarthritis, etc. And it's important to note that even if you have a scan that is bone-on-bone, grade 4 and severe this, it doesn't necessarily mean that you're going to suffer from pain. In fact, there's a lot of people out there that don't have any symptoms whatsoever, never had a scan that would have a scan that looks as bad as this. But why is that, and what can we do? Because I see largely people at the end of the disease spectrum, people that are on a waiting list, waiting for 12 months for surgery. But about 80% of those people haven't had any real exposure to an appropriate tailored exercise program. And tailoring the exercise is what's important, because anyone can just say, go for a walk or go for a whatever. So we'll dive a little deeper into that as well. So when we talk about the severity of osteoarthritis, there's a number of different factors that we look at which define what is severe, well beyond just what the scans say. So we look at things like whether you're getting pain at rest, whether there's malalignment, whether there's muscle weakness, whether you need to use a walking aid, whether you're reliant on pharmaceuticals, your ability to perform activities of daily living. And invariably, in my clinic, we're able to get people, irrespective of what their scans say, from that red zone, that severe zone, on their way down towards the green zone. There's a number of modifiable factors which can escalate or accelerate a person's osteoarthritis disease. One of these is high impact activity. So we don't necessarily put a cross through high impact activity altogether, but if you've already got osteoarthritis, the types of sports like tennis and running and jumping and twisting and turning may not necessarily be the best form of exercise as your primary form of exercise. It could be something you can work towards to do once a week in a very modified manner, but definitely not your primary form of exercise. Obesity, probably 80%, 85% of the patients I see in my clinic are overweight or obese. And so this is a modifiable factor. It's not easy to lose weight, but we're getting better and better at our methods at assisting people in being able to lose it. For every kilo extra that you carry, there's 4 kilos of extra force going through your knee joint. Okay, so we also know that a 5% reduction in your body weight in conjunction with an exercise program focused on strength can reduce your pain by 30%. A 10% reduction in body weight can reduce your pain by up to 50%. And then we've got muscle inhibition, and this is a key one that 99% of the patients that I see, because I do a lot of muscle testing, 99% of the patients I see suffer a degree of muscle inhibition. And this is an example of that, or a severe example of that, is when you're walking along and the leg gives way on you. And every time that happens, and even at a much less obvious level, you're causing trauma to the joint. You're causing unwanted torsional and all sorts of different unwanted forces to the joint, which can add up and lead to a sore, swollen joint. So this all leads to unwanted forces, increased joint, unwanted movement, increased joint forces, and joint pain, and ultimately it will get to the point where you've got a swollen, painful joint. What's the antidote? Well, it's exercise, but it's not just as simple as that. It's a tailored exercise program. Everyone's different, and everyone's coming from a different starting point. There's a lot of misconceptions and myths associated with osteoarthritis, a lot of which cause people to develop fear and feel like their joints are going to crumble from under them, and lose a lot of confidence and cause them to be isolated and not want to leave the house. Exercise will worsen my arthritis. Walking hurts my joint, therefore I should avoid walking. I have bone-on-bone arthritis. I must have an operation. My hip and knee will inevitably deteriorate. All of these, to certain degrees, are false statements. We know that the right type of exercise is absolutely essential to the health of your joint. Okay? Again, that may be very different from one person to the other about the type of exercise they can do to start off with, but in a progressive gradient fashion, we can increase that level of exercise. The weight we put through our bones helps those bones to remodel and maintain their strength. The movement and the forces we put through the joint help to maintain the health of the cartilage. Okay? They help to move the fluid around the joint to provide nutrients to the cartilage. It helps to make the muscles and the soft tissue around the joint. It prevents them from stiffening up. It increases their elasticity. And also the muscles, as we talked about before, it increases their strength. And as I said before, irrespective of what the x-rays say, there are many people out there, and it's the same sort of thing with backs. You know, people will go and get MRIs of their backs, and invariably they'll say they've got broad-based disc bulges and stenosis, this, and all these nasty sounding things. But they've done a study on 100 people that didn't have back pain, just to see what they'd find on their MRIs. Over 80% of them had broad-based disc bulges and all these horrible sounding different things. So these sophisticated scans are very good at helping us diagnose things, but to some extent they've probably made us a little bit trigger happy for surgery and trying to fix things before we allow natural recovery to occur, or we put people on the right type of an exercise program, identify the factors that are causing them to flare up and get them back on the road to recovery. What you've got to remember is your joints are far more robust and resilient than you give them credit for. And sometimes we just need to give them a little bit of direction to get them back on track. So exercise, is it good? It is. It's fantastic for our joints. And this has been proven time and time again from the highest level studies, a collection of the highest level studies that we call systematic reviews, and then meta-analysis. So it's been studied left, right and centre. The jury's out. Exercise helps. It increases mobility, stability and flexibility. It increases strength and increases posture and balance. It reduces pain, it reduces fatigue, and it reduces muscle tension and stress. If we compare it to non-steroidal anti-inflammatory drugs, which can be quite beneficial, as has already been pointed out, strength training itself actually is very effective. If you look at this, this graphic here, what we're looking at, the blue bars going to the right, is a benefit score, which is basically looking at a collection of all the best research in regards to pain and function. And it's looking at what kind of benefit there is. And a score of up towards 6 is starting to have a pretty significant benefit score, and anti-inflammatories do a pretty good job. They're quite effective. Problem is, they've got a big risk score if you look at the red bars going the other direction. So tummy ulcers, worsening hypertension, stroke, kidneys, etc. Now, strength training, very similar, if not better, with regards to pain relief benefits and increased function, don't have the risk scores. Exercise also has a significant impact on chronic pain, and it does this in some very complex mechanisms, but what it does is it helps to increase our pain threshold. So essentially, what happens with regards to regular exercise is it desensitizes a joint. Often when people have a sore joint, they won't exercise, they won't do too much, and the nerves around that joint, they will respond to pain with much less stimulus, okay? And also changes occur in the central nervous system around the brain and the spine. We know that with ongoing exercise, we're able to endure much more trauma. Well, trauma's the wrong word, but just much more impact to the joint before any register of pain occurs. So there's all sorts of different types of exercise. Strengthening has been shown to be one of the most important, okay? And there's a number of different types of strengthening exercise that you can do, and I'll show you a couple of examples in a tick. Aerobic exercise, which is basically where we're trying to get our heart rate up, is very important for a number of different aspects of our health. Flexibility, so you're stretching or basic yoga type exercise, and then you've got your balance, which you can get through your Tai Chi. You can get it from swinging a golf club, just walking. High impact versus low impact exercise. As I said before, you don't necessarily have to rule out high impact exercise if you've had a confirmed diagnosis of osteoarthritis, but you've got to see what kind of an impact a game of tennis or a bit of a run actually has on you whilst you're doing it and then post the exercise. And it may well be the case that it's just not simply appropriate to you, or it may not be appropriate to you until you start losing some weight. So the preference should really be on that low impact exercise, and there's a wide variety of things you can do on the bike, walking, swimming, etc. Ideally, if you look at all of the guidelines, we should be exercising for at least 30 to 60 minutes every day, 5 to 7 days a week. A moderate intensity is ideal, so that if you're walking with your partner, you can still carry out a conversation, but you're a little bit puffed. That's that kind of perfect exercise intensity. But bear in mind, you may well have a number of other health conditions like cardiac complaints and whatnot as well. So these are conversations that you need to have with your health professional, and this is why exercise needs to be tailored, and these discussions need to be had with your GP, with your physiotherapist, your exercise physiologist, etc. Here's some examples of some strength training, and don't necessarily go home and do these straight away, because as I said, they need to be tailored to your particular type of problem. But you can see someone there doing wall slides, which is a form of squatting. Sit to stand without using their hands. A seated leg extension and a double leg heel raise. For example, we'll get someone to do that 15 times and repeat that twice. And I'll try and get them to do it at least 3 times per week. That's just a really rough guide of a type of strength program that I'll give patients. But very rarely will I give exactly the same exercise program to the same 2 patients. So when we're considering exercise, we need to consider the amount of load that that patient is able to tolerate with respect to what that joint is able to take. Quite often the reason why we develop symptoms in the first place is because we've overloaded the joint. We might have gone to France and done the stairs of the Sacré-Cœur, or we've gone to Dubrovnik, and we all know that's full of steps, and that was the trigger that set us off, because we just weren't prepared for that level of activity. And so we need to find where that starting place is, and in a very graded fashion, slowly expose ourselves to more activity so the joint can adapt bit by bit. So where is that starting line? For some of my patients, the starting line, because I'm seeing a lot of very end-stage osteoarthritis patients, and just bear in mind that probably about 60% of the patients I see, as I say, are off the wait list. I've got them for about 12 months, largely preparing them for surgery. But for 15% of those patients, because they've lost a bit of weight, because they've got a lot stronger, they've actually decided to pull themselves off the wait list and not have surgery because of the improvements derived. So this is end-stage people. So if it's helping people with that end stage, you can imagine the impact it can have if you're not quite at that point. And hopefully you can keep away from a surgeon's knife. Now that's not poo-pooing surgery. Like, without doubt, it's one of the greatest advances with regards to osteoarthritis management, total hip and total knee joint replacement surgery. Okay, but only for when you get to the stage where you need it. It should be the end stage. Unfortunately, for a lot of people, it's the first thing that's gone towards. So you've got that person over there lying on their back, tightening their quadricep muscles, the muscle above their knee, and doing a straight leg raise. For some people, that's where we start, what we call unloaded exercise. And you might need to do that for a month, 2 months, to build up enough strength to get to the point where you're able to do more loaded exercise, which the next point might be in the water, where you're doing some hydrotherapy. You might progress from there to start doing some increased weight bearing on the bike, and then onto some walking. Eventually you might be getting back to what you're passionate about, getting back on the golf course, getting back onto the tennis court, kicking the soccer ball with the grandkids. With regards to pain, as I said before, pain doesn't necessarily equal damage, but we shouldn't ignore pain altogether. Sharp, lacerating pain, pain that persists for more than 30 minutes after we've ceased exercise is probably an indication that we've overdone it, and that we've either exercised too much or that type of exercise isn't quite appropriate for us. But mild discomfort during and after exercise, don't be afraid of that. This is pretty normal, and this is something that we need to learn to be able to accept, that it's a part of the condition. And over time, you might find that that mild discomfort becomes less and less. Analgesia prior to exercise is not a bad idea either. You know, so we've already been mentioned some of those different types of medication you can take. If that enables you to go out and exercise, you're better off having the medication than to not have the medication and stay in the armchair. The consequences of being sedentary are far worse for you in most cases. Flares is where there's a sudden increase in pain. They're a very common issue with osteoarthritis. And learning how to, in the first instance, not fear them, accept that these will happen from time to time, dial back on your level of activity, and then in a graded fashion, slowly build things back up again. Incidental versus a structured exercise program. If you're like me, I'm a little bit lazy. I don't really like the idea of having to go to the gym at a certain time. Okay, and a lot of people like that. My old man, my dad, he loves it. He loves the idea of waking up at a set time and doing a set number of exercises, and that's what works for him. But for many of us, exercise can be about embedding incidental exercise into our everyday activity. I'll never forget going to the gym in the UK, and there wasn't much parking for this particular gym. And people would come in and they'd be blowing up at the poor reception staff, and there's no parking here, I had to walk a couple of blocks. They come in and then they get on the treadmill. And so people, what you need to realise is that exercise takes many different forms. And if you can integrate that exercise into your daily routine, you're not even really realising that you're doing it. It might be doing some calf raises while the veggies are boiling, or every time you go to get a plate out of the bottom cupboard, do a couple of squats while you're there. So integrating that exercise into your everyday routine is just as effective. What gets measured gets done. So we live in a fantastic age now where half of us more are carrying iPhones. They've got little step counters. We've got little apps that measure different types of activity we do. If you're more traditional, the good old calendar is just as effective. It's quite rewarding to see on that calendar or see on that phone when you've actually reached, say, 7,000 steps, which might have been your target that you set with your physiotherapist. It can be very rewarding just to know that you made it and did your 10 squats. So having that visually in front of you is actually a very strong motivator. Assistive devices can play an important part. Just using a walking stick effectively can unload your joint by 10%. That can be enough that take you from walking only 5 minutes to your letterbox to 25 to 30 minutes to be able to go down to the road to get your paper. Okay, there's a stigma associated with using a stick, but invariably when I say to people, you know what, just borrow this one, borrow the hospitals, use it for a week or two, see what you think. 9 times out of 10 people come back and go, you know what, no one really could care less whether I was using the stick or not, and my goodness, it's made a difference. And quite often those people, once they're starting to walk more, they start to develop more strength and then they get rid of the stick anyway. Walking poles, appropriate footwear, orthotics, all sorts of ranges of different types of knee braces can be effective for arthritis as well. I'm conscious of time, so I might whiz through a couple of these extra points. How are we going for time? Are we a couple? Yeah. I just want to finish off, I want to emphasise the impact that weight loss can have for those who carry extra weight. That's that 10% reduction in body weight and the impact that can have on pain. Heat and ice, don't discount how effective they can be in controlling pain. The only time I would not recommend heat is if your joint's inflamed or you've recently injured it. Otherwise, both can be equally effective. Depression, anxiety, stress, very common with osteoarthritis, can actually lead to a worsening of your symptoms. You can talk to your GP about getting a mental health plan set up. There's also online programs that are in place. Macquarie University has a really good program. I'm sure Ruth will be able to give you access to these slides afterwards if you're interested. Hands-on physiotherapy can be a very beneficial adjunct to being able to do exercise and relieving pain. And at the end of the day, I love this quote, a journey of 1,000 steps begins with a single step. Sometimes it's daunting, the thought of having to create a new habit or do something new is overwhelming. But just taking that first step towards doing something different can be the most important thing to making huge changes in your life. Thank you very much.
Okay, just going to invite all the speakers, and Andrew, of course, who's a qualified exercise physiologist. So with Matthew, he'll certainly have a lot to say about exercise and what's good for you. So we have roving mics, Ruth and Michelle. Michelle hiding somewhere with a microphone. Okay. One question, someone? Questions? Anybody? No questions? Ah, yes, okay. Gentlemen, hello, sir. Yeah, right in the middle here. Thank you. Mr. Ackerman. There he is. Questions, not statements, please.
Thank you very much. Yeah. I've just recently been diagnosed about 6 months ago that I've got osteoporosis of the hip, and a couple of medications were mentioned to me. One is the Prolia, and the other one is Actonol, which I'm actually started taking now. Just wanted to know which one is more effective. What are the considerations to decide what's appropriate?
Well, I don't like to answer specific questions for individuals, but what I would say to you is the Prolia and the Actonol and the Aclaster, which are the sort of 3 most common ones, there is very good evidence that they all work and that they're relatively similar. And it often comes down to personal preferences, that somebody will say, having to take a tablet once a week, even if I have it with breakfast, which you should have it with the Actonol if it's in the EC form, that suits me. Somebody else will say, no, I hate taking tablets. I'd rather have an injection. It's the doctor's problem. I go once every 6 months and I have the injection. And other people say, oh, no, I don't want an injection, but I'm happy to have an infusion. And all of these things work, and it's really a matter of just discussing what you prefer. There's very little evidence of really a difference in efficacy, i.e. how well they work, or in safety, what sort of side effects there may or may not be.
Okay, so just for a point of issue, we have a physiotherapist and exercise physiologist, and many of you won't know what an exercise physiologist does compared to a physio. Please, Andrew, just enlighten us, because I think it's important to know that when you get referred for exercise or assessment of what's good for you, that certainly both professionals will be of assistance here. Just quickly, just a short, if you can.
Well, thank you for raising that sort of interesting point of contention. And I've worked on a spiel over my many years of practice of defining that an exercise physiologist is trained in how we really use exercise as a very robust treatment method for a whole range of chronic diseases. And I suppose chronic disease is the central point of difference here. Chronic diseases are things that we can live with from as minimum of 3 months and upwards, so things like osteoarthritis, osteoporosis, diabetes, cardiovascular disease, things that we might be living with for the rest of our days. We're trained in how to utilise exercise, as Matt suggested, in terms of making a tailored, individualised program and understanding the very many complex components to utilising exercise effectively, and again, as Matt suggested, with minimal side effects or risks, how you can use exercise to manage those conditions. And I think, that's the major point of difference between a physio and an exercise physiologist. And there's a few diagnostic components that a physio is capable of doing that an exercise physiologist isn't, but we also work quite collaboratively within many health settings. So you're probably likely to encounter both within a practice or a hospital setting. So thank you for that question.
Okay. Question just behind here. Yeah, there's plenty, yeah.
Right up to my mouth, okay. In relation to the interesting talk on fractures, I wondered whether there's agreement on what a fracture is, because after I fell in Israel, a clinic there diagnosed me as having a fracture of the arm and plastered it and did all sorts of things, and said to see a doctor in some 6 weeks, which was in Canada, where they then said, you probably didn't have a fracture after some more x-rays. So I wondered whether there's agreement on what a fracture is.
Yes. pretty much 100%. But sometimes you can get a very slight fracture, like a hairline fracture, and over a period of 6 weeks it may heal enough that people can say, well, we're not sure that it really was there, because it looks like it's healed. But usually it's pretty clear. That's almost everywhere. The one place where it's more difficult are the ones in the spine, because there you don't see fracture lines. You see a vertebra that, instead of being a nice square box, is squashed down a bit. And knowing whether it's actually something that's squashed down or not is often quite difficult. But other than that, we pretty much 100% agree.
Okay.
So does that mean that the doctor who first x-rayed me and said you've had a hairline fracture, as it were,
right.
would be more likely to be correct?
That's correct.
Probably.
Okay. Michelle, over the side there. Yep.
Could you please tell me, does a medication like thyroxine contribute to bone thinning if you're taking thyroxine long term for hypothyroidism?
No, it doesn't. If you have too much, and it is possible to have too much, and that's modified by the things like the thyroid stimulating hormone, that's in the normal range. If that's normal, then you're on the normal amount and you should continue it. If you have too much, or if you have an overactive thyroid, yes, it can contribute to bone loss, but not if it's adequate replacement.
Just over there, one more on that side, then we'll come back this side.
Thank you very much. It was quite an interesting talk. I wanted to ask, the medicines that you talked about for osteoporosis, do they have a life expectancy? In other words, can you keep taking them for 5, 10 years, or is there a time limit?
Okay. This is a very interesting question. And the answer is, what we have is evidence that when people have been studied and the drugs have been continued for 10 years or so, they seem to be working. There seems to be benefit. But as I said, we don't have a, quote, control group because it's unethical to do it. Some of us look at it and say, you know, glass half empty, glass half full. Some people say, we don't have the evidence that for 10 years it's still working. I look at it and I say, we don't have anything out of 10 years that says it's not still working. But as it's been alluded to, when you've got osteoporosis, you've really got it for life. It's really the same as saying you've got blood pressure or diabetes or high cholesterol. We never go to the doctor and say, I've got high cholesterol. I'll only be treated for 3 years. I mean, this is a chronic condition. There are times when you can look at it and say, you know, I've responded very well. Do I need to continue? And that can be a discussion. It can often be quite a difficult discussion for a variety of reasons that are a bit beyond what we can discuss here. But it is something that you really have to have very good reasons to stop it. The condition has not gone away.
Just a question for Professor Day, if I may. Hand over the microphone. Often people are sort of mixing their paracetamol with a Nurofen or the Voltarens. Would you say long-term that's a good idea, or has that person, they've done their exercise, seen the physiologist, got their program? So if they're finding something that helps, does it matter if they mix up the sort of the weak and the strong? Is that an issue, and how long should they be doing that?
Yeah,
a bit closer.
It's a perfectly safe to use the combination of paracetamol and an NSAID like ibuprofen. I think that's quite commonly done. And if that does help by adding them together, that's okay. I think the drug to think about, or the class from the safety point of view, is the non-steroidal anti-inflammatory drug. And if there are risk factors for those drugs, I think you ought to use them only for as long as you really get help with your symptoms, and then back off. And I think I'd always test whether or not you could back off, because there's no doubt if you happen to have hypertension, for example, there is a chance that when you take NSAIDs, the blood pressure will go up. If you have heart failure already, these drugs can contribute to that.
Okay, now we talked about methotrexate, which was used in cancer therapy early on. So
Yeah.
how's that going long term?
Yeah, well, that's very interesting, because people are very concerned about methotrexate.
Have to a bit loud. Put it close to
I
you.
beg your pardon?
Yeah. Close.
Oh, sorry, repeat the question. So the question here was methotrexate, which is very commonly the first real anti-rheumatic drug used for rheumatoid arthritis and some of the other inflammatory arthritises. It was invented to treat cancers, but given in very much bigger doses than we use now. And unfortunately, a lot of the information in the product information reverts back to that experience. So when you read the product information, it can be quite scary. But we know that if we use the doses that we do, we actually monitor the blood, not too often, blood count and liver function test. But even that, I mean, it's very unusual to see anyone who has a problem there. And really, they're tolerated and safer in lots of ways, I think, than a Nurofen class of drugs for people, particularly who have risk factors for that bunch of drugs.
Another question up there? Yep. Thank you. Yeah, we've got... Well, just we'll have one lady here first.
I have a totally useless left hand with arthritis. I can't even put a fork into the meat or cut it at all. Is there a chance of, or something which could straighten out the fingers?
A general surgical question.
Thank you. Yes, I think it depends very much on what the cause of this is, how long it's been there, and what the mechanism is. So I guess there are all the physical approaches which you may have tried. Sometimes with the inflammatory arthritises, we end up with the surgeon even replacing knuckle joints and so on. It's not something we rush to because it's quite challenging to rehabilitate. But if it's due to arthritis itself, I think there's probably a lot of merit in actually exercising even the small joints and muscles of the hand, but that's a tough one as well, particularly if it's advanced and gone on. So hard to be sure depending on the situation.
It may even be worth seeing an occupational therapist. It's a different type of health professional as well. They can provide assistive devices and different ways that you can hold a fork and hold a knife, oversized handles, all of that sort of thing. Also bracing. There's different types of splints and whatnot that can help support the joints a little bit as well. So that's worthy of consideration too.
Oh, well.
Oh, you tried and didn't have any luck? No.
In the same vein as what Matt was suggesting around assistive aids, there are organisations like the Independent Living Centre and Assistive Aids Technology, organisations that create like quite a comprehensive suite of products ranging from quite simplistic to very sort of sophisticated that can be utilised for all sorts of given tasks. The Independent Living Centre, by reference, sort of have products relating to grooming, the garden, kitchening, the kitchen and cooking. So there may be some simple products that you may not have been exposed to, and it's worth having a look down those pathways.
Michelle, over this side. Gentlemen, yep.
Is it on? Yeah.
Yep.
Okay, I tried to make it intelligible and quick. I've been taking on and off high doses of prednisolone for the last 4 years. I'm just being weaned of it. I'm down to 5 milligrams a day. Another week and then hopefully that's it. And I'm not overweight, never been, always been doing sports. I'm very fit normally. And just last week, my GP asked me, with all this prednisolone, I'd like you to have a bone density test. I got it, and I was a bit taken aback because it was a minus 2.475, which is nearly osteoporosis, right on the borderline. The question is, when I'm off the prednisolone, if I can be off totally, they also got a jab in my stomach, I forgot what it's called, that against osteoporosis. Can it improve itself with the medication? I'm taking nothing orally, just that one injection, and she said that I get another one in 6 months.
Okay, so prednisone really is fantastic for some autoimmune and inflammatory disorders. It's a life-saving treatment, but it also does have adverse effects, including on bones. We would often argue that if someone knows you're going to be starting on prednisone for a long period of time, you should have had a bone density done at the beginning of that, and depending on what it looked like, you maybe should have had that treatment right at the beginning, okay, rather than at the end. But having said that, once the prednisone stops, often you can get a big improvement in bone, okay, even without any other intervention. The other thing is that as the bone density goes down, and we didn't talk about that, but as the bone density goes down, the risk of something breaking goes up, but it's a continuous change. I know we talk about osteoporosis being minus 2.5, but that's actually almost rubbish. It's just a point that people have drawn in the sand. Medicine loves drawing lines in the sand. But in fact, you know, between minus 2.47 and minus 2.57, there's really no difference. And there's not much difference to minus 2.37. And so don't get caught up with a simple number like that. And you might well expect that this will improve. Now, you're on the injections. That's the Prolia every 6 months. The thing that you do need to know about that, and this is true for anyone who's taking Prolia, and it's true for any of the treatments for osteoporosis. You have the treatment, you get an improvement in the bone density, you stop it, and you gradually, the effect wears off, and you lose what you might have gained. With Prolia, it's actually quite interesting. That's only a doctor could say that, I guess, because it goes up like that, but when you stop, it actually can go down extremely rapidly. So 6 to 12 months after you've stopped, you might have lost all of what you gained over several years previously. So if you're on it, that's fine, but you really do need to probably have some specialist discussion about what you might do if you think you want to stop it. And just finishing the prednisone is not a good reason to stop it.
Okay. Thank you. One last question, because we have time, unfortunately, in this theatre.
Yes, good evening. Just one question, please.
Can
you... Okay?
Yep.
Right. Yes. My question, please, is complementary medicines, that's to say natural substances packaged in capsules or pills, are for arthritis. Are any of those accepted by mainstream medicine as being both safe and effective?
Certainly safe. Effective is where the problem is. So effective in the eyes of the beholder is sometimes helpful, but really the evidence for particularly slowing any form of arthritis is not really available in the sort of evidence that we would be enthusiastic about. But it's very fair to say that a big proportion of people take these medicines and it provides something to them. So we don't, we'd like to know about it, because sometimes there are interactions and adverse effects, not too often. But in terms of having an effect, even measurable like Nurofen, it's pretty hard to see that.
Right. Yes, one substance that was mentioned to me recently by a friend who's into this sort of thing, I'm not really, but it's turmeric. Along with some other ingredients.
Yes, turmeric. That's right. I think work's still going on to see whether or not that helps. Certainly people feel it does, variably. But again, the sort of high quality studies to really make the point, so that would go into a guideline, we haven't really got.
Thank you.
Thanks very much.
Okay, thank you. So just in summing up, it's a big issue, arthritis and osteoporosis. We've heard a lot about it tonight. We have Arthritis New South Wales, Arthritis Australia, Macquarie University. You have the Wolper Wellbeing program. You have your local physio, GP to consult, and the rheumatologist you may have to see. So many things to consider. We had to make a change on our next Wellbeing meeting that was previously advertised in November. It will be Wednesday the 23rd of October, Care for Carers. Julie McCrossan will not be attending, but we do have a new moderator in Mr. John Mangos, who's a very popular journalist, sports and media personality who will be entertaining you in the Q&A that evening. There's also a study being done by a colleague, Larry Cohen. He's left a small brochure out there for people that do have that stooping problem. He'd be interested to know if you'd like to be part of his University of Sydney program. To the people here, I'd like to say thank you very much to our guest speakers. And for all the new faces here, please know that we'd like to keep in touch for next year's program, so please leave your email contact, would be very helpful so we can keep in touch. And thank you and have a very good evening.